We will now discuss Thyroid Storm. Welcome to our channel, Internal Medicine Made Easy, the online learning platform that provides medical education to healthcare professionals and students to improve their clinical skill and help them in their studies, courses, careers, and research. Thyroid storm, also known as thyrotoxic crisis, is an acute, life-threatening complication of hyperthyroidism. It is an exaggerated presentation of thyrotoxicosis and is characterized by compromised organ function. Whilst rare in the modern era, the mortality rate remains high, 80 to 100% without treatment. Even with treatment, the mortality rate is between 10 to 50%, according to clinical research and study reports. Prompt consideration of this endocrine emergency with specific treatments can improve outcomes. Etiology: superimposed precipitating factors cause thyroid storm in patients with diagnosed or undiagnosed hyperthyroidism. It is more common with Graves' disease, but can occur with other etiologies of hyperthyroidism, for example, toxic multinodular goiter and toxic adenoma of the thyroid. The precipitating factors are abrupt discontinuation of antithyroid medicine, thyroid surgery, non-thyroid surgery, and trauma. There are some other causes like acute illness like infections, diabetic ketoacidosis, acute myocardial infarction, cardiovascular accident, cardiac failure, drug reaction, parturition, recent use of iodinated contrast medium, radioiodine therapy, burns, stroke, medication side effect, for example, amiodarone, anesthetics, salicylates. Pathophysiology: a precipitating factor, as mentioned before, is always required to cause thyroid storm. Those precipitating factors cause a rapid increase in thyroid hormone levels, which is responsible for the incidence of thyroid storm. The hyperactivity of the sympathetic nervous system with increased response to catecholamine, along with an increased cellular response to thyroid hormone during acute stress or infections, causing cytokines release, and altered immunological disturbances are other possible mechanisms of thyroid storm. Clinical features: presentation of thyroid storm is an exaggerated manifestations of hyperthyroidism with the presence of an acute precipitating factor, fever, cardiovascular involvement including tachycardia, heart failure, arrhythmia, central nervous system manifestations, and gastrointestinal symptoms are common. Fever of 104 to 106 degrees Fahrenheit with diaphoresis is a key presenting feature. Cardiovascular manifestations include tachycardia more than 140 heart rate per minute, heart failure with pulmonary edema and peripheral edema, hypotension, arrhythmia, and death from cardiac arrest. CNS involvement includes agitation, delirium, anxiety, psychosis, or coma. Gastrointestinal symptoms include nausea, vomiting, diarrhea, abdominal pain, intestinal obstruction, and acute hepatic failure. Evaluation: the diagnosis of thyroid storm needs clinical suspicion based on the presentation mentioned before in a patient with hyperthyroidism or suspected hyperthyroidism. One should not wait for lab results before starting treatment. Thyroid function tests can be obtained, which usually show high FT4 or FT3 and low TSH. It is not necessary to have a very high level of thyroid hormone to cause thyroid storm. Other lab abnormalities may include hypercalcemia, hyperglycemia due to inhibition of insulin release, and increased glycogenolysis, abnormal liver function tests, high or low white cell blood cell count. Management. Treatment of thyroid storm consists of supportive measures like intravenous fluids, oxygen, holding blankets, acetaminophen, as well as specific measures to treat hyperthyroidism. If any precipitating factors, for example infection, are present that needs to be taken care of, patients with thyroid storm must be admitted to the intensive care unit with close cardiac monitoring and ventilatory support if needed. Specific strategic steps for treatment: therapy to control increased adrenergic tone, beta blocker; therapy to reduce thyroid hormone synthesis, thionamide; therapy to reduce the release of thyroid hormone, iodine solution; therapy to block peripheral conversion of T4 to T3, iodinated radiocontrast agent, glucocorticoid; propyl thiouracil and propranolol; therapy to reduce enterohepatic recycling of thyroid hormone, bile acid sequestrant. After initial supportive measures, a beta blocker should be started for any case of suspected thyroid storm. Typically, propranolol 40 mg to 80 mg is given every 4 to 6 hours. Then either a loading dose of propyl thiouracil 500 to 1000 mg followed by 250 mg every 4 hours, or methimazole 20 mg every 4 to 6 hours should be given. An hour after the administration of propyl thiouracil or methimazole, give 5 drops of supersaturated potassium iodide by mouth every 6 hours. Always administer thionamide before starting iodine solution therapy. This prevents the imminent increase in thyroid hormone synthesis due to increased iodine load from supersaturated potassium iodide. If available, oral cholestyramine 4 grams 4 times daily can be started for severe cases. One should look for precipitating factors and treat them accordingly. In the first 24 hours of treatment, propyl thiouracil decreases T3 level by 45%, but methimazole drops T3 level by only 10 to 15%. Methimazole, whereas, causes more rapid normalization of serum T3 level after a few weeks of treatment, and it has less hepatotoxicity compared to propyl thiouracil. Therefore, after initial stabilization, we should treat with methimazole. If propyl thiouracil was started at the beginning, it should be changed to methimazole. Once patient's clinical conditions improve, the iodine solution should be stopped. Glucocorticoids can be tapered and stopped, and beta blocker should be adjusted. Thionamide therapy should be titrated, and if propyl thiouracil is used initially, it should be switched to methimazole. Patient should be recommended for definitive treatment with radioiodine therapy or thyroidectomy. If thionamide therapy is contraindicated because of an allergic reaction, thyroidectomy is needed after treatment with a beta blocker, hydrocortisone, cholestyramine, and iodine solution. Plasmapheresis is the last resort if all other measures fail. Surgery may be required in patients with Graves' disease for the treatment of hyperthyroidism. These patients need to be pre-treated with beta blockers, glucocorticoids, and iodine formulas. Surgery is usually done after 5 to 7 days.